23-year-old comes to the emergency department due to sudden onset fatigue and dark urine. Please be careful from dark urine. The patient was recently diagnosed with dermatitis herpetiformis. He began treatment with dapsone. Please highlight this important drug. And gluten-free diet for 3 days ago. This morning, the patient felt weak and had a difficulty getting out of bed. His urine also appeared dark. Temperature is good. Blood pressure is good. Pulse good. Respiration good. The patient appears tired. Examination shows scleral icterus and pale lips. About scleral icterus, this is jaundice, elevated bilirubin. Please don't forget this. The eye turned to yellow. There's a papular rash along the scalp, elbow, and knees with overlying exudation. Laboratory is following. Hemoglobin is low. Reticulocytes is high. Please, this is this type of anemia. This is hemolysis or aplastic anemia. Don't forget, reticulocytes higher than 1 to 2%. This is hemolysis. Okay, the keyword for hemolysis, that is dark urine and scleral icterus. Okay, we have a lot of distraction. Don't be confused with. This is okay. The distraction is papular rash along the scalp, elbows, and knees with overlying excoriations. This is dermatitis herpetiformis. Don't be confused with this dermatology problem. Okay? Hemolysis, we see blood, but we don't see red blood cells. Wow. How it's gone? There is blood, but no red blood cells. Okay. This is the type of hemolysis when we see red blood cells, meaning the blood go out from the kidney, okay, or from the ureterus, or from the bladder. Okay, this is red blood cells. But by meaning blood, there is RBC content, or meaning hemoglobin, or something inside the red blood cells. Okay, this meaning blood, or maybe the urine color is bloody. Okay, don't confuse between blood and RBC. To conclude, when we spoke there is blood, there's no meaning there is RBC or red blood cells. Okay, this is important things. We'll talk about this later now. Which of the following is most likely mechanism for this patient's urinary finding? Is this autoantibody production, or complement activation, or immune complex deposition, interstitial leukocyte infiltration, or exudative injury? Does anyone have any answer? Okay. Okay. Please be careful with this type of question because the dapsone is the keyword. Okay. This is oxidative injury. We will see why and eliminate the other answers. Okay. What about autoantibody production? It could happen with hemolysis blood or hemolysis anemia. The similar to this case. But because we have dapsone, so this is oxidative injury. And the important information that lead us to G6PD or glucose 6-phosphatase dehydrogenase about the man and the younger age. Okay, about 80% from the hemolysis or any immune problem, this is female. Okay, not man and female, man or woman and woman, the same person. Okay, the autoimmune disease affects women more than men. Please be careful from this information. So this is oxidative injury. The patient had hemolytic anemia, but not because of autoimmune. This is because glucose 6-phosphate dehydrogenase. Okay, the keyword is hyperbilirubinemia and hemoglobinuria. Okay, about antibody-mediated hemolysis is seen with warm or cold. We'll talk about them. But certain medications can also cause immune-mediated hemolysis. But most cases are linked to cephalosporin, penicillin, or NSAIDs, non-steroidal anti-inflammatory drugs. In contrast, dapsone is classically linked with G6PD problems. So please be careful from the drugs, not any hemolysis, meaning immune hemolysis. It could be G6PD or antibody-mediated hemolysis. About the other answer, we spoke about them, complement activation. I will keep it with you to study when you memorize this session, okay? To save your time. About cold agglutinin disease and warm agglutinin disease, very, very, very important, okay? Both of them hemolysis, but cold agglutinin, meaning that happen in areas below core body temperature, like this type, like ear. This is areas that cold than other part of the body that happen inside the blood vessel. So this is intravascular hemolysis happened with IgM. Okay. The cause of cold agglutinin mycoplasma pneumonia or malignancy. But warm agglutinin disease happen at core body temperature, like in chest in this picture, by IgG, and happen where extravascular hemolysis. Okay, so please be careful. Causes of warm agglutinin medications: SLE and CLL. CLL meaning chronic lymphocytic leukemia. Okay, this is important question, and I just want to keep this table with you, please. Okay. Another case, 23-year-old man comes to emergency department, severe abdominal pain and fatigue. Please be careful. This is severe abdominal pain, but hematology case. So hematology that make good relative with other topics. Okay. He has had nausea, vomiting for several hours, and is unable to eat. He took ibuprofen but has had no pain relief. The patient has a history of anemia and dark brown urine that hasn't been evaluated. Okay, because he tries to avoid going to the doctor. Dark urine meaning there is hemolysis. Okay, review of symptoms is negative. No medical. Migrated in the childhood but not traveled outside the United States. This is all distraction. There is high temperature, okay, blood pressure good, pulse good or not good. What do you think? 23-year-old. It's elevated, but we can, because it's dark. Okay, yes. What do you think about this high heart rate? Can anyone tell me the reason to focus on and not in the exam that confused you? Okay, I will tell you. This high or heart rate or tachycardia because of temperature. Okay, when you see tachycardia with temperature, this is normal. Okay, please be careful with this notice. There is dandruff in the right upper quadrant of the abdomen that exacerbated by deep inspiration. Splenomegaly and jaundice are present. There are no peritoneal signs. The remainder of examination is normal, and we have the lab. Okay, what do you think this patient has? Severe abdominal pain and dark urine, but not stable. Go and wrong. Uh, tenderness now in the right upper quadrant of the abdomen. Does anyone tell me the reason? Okay, this is inflammation of gallbladder. Okay, this is the scenario for cholestasis, but the problem is because of hemolysis. Hemolysis makes stones, but this is bilirubin stones accumulate with each other and cause stones and cholestasis. Okay? But this is not the problem we want to speak about. Leukocytes is good, hemoglobin below the normal, MCV good, MCHC we'll talk about this later. Reticulocyte is high, so we have hemolysis. Platelets good, bilirubin elevated, ALT and AST is good, lipase is good. Okay? We have blood type serum LDH. Combs test is negative. This is very important keyword that or hint that he gives me. Combs test meaning no immune hemolysis, not antibody attached to the RBC. Which of the following most likely primary cause of this patient's anemia? Because acute hemorrhage, no. When we have acute hemorrhage, no elevate of reticulocytes. Autoimmune hemolysis, no, because Combs test is negative. Genetic red blood cell, we will see. Malignant bone marrow inflammation, no, because platelets is good and leukocyte is good. And no malignancy red flags. Okay? The age is good, no problem. What about medication side effects? We will see viral suppression. When we see viral suppression, the three chains will be lower than normal. Okay, so this is not viral suppression. Vitamin deficiency, not acute. Okay, and the vitamin deficiency we don't have reticulocytes. So the problem is genetic red blood cell defect. Let's see what this is. Okay, let's talk about evaluation. When you have hemoglobin, this table is very important. When you have low hemoglobin or anemia, go to MCV. Low MCV, one of these four causes, or higher MCV, the most common, this is true, vitamin B12 or folate. When there is normal MCV like this patient, go to reticulocytes. If it's low, so is leukemia or plastic anemia. Elevated, this is hemorrhage or hemolysis. Okay. The hemolysis causes are spherocytosis, G6PD, autoimmune, microangiopathic. Microangiopathic meaning like a DAC and SLE that we spoke the last session. Okay, so the keyword we have hemolytic anemia, splenomegaly, the cause of hereditary spherocytosis. I will talk about this disease later. So now let's take introduction of this disease. It's inherited of red blood cells because of no protein spectrin and enrictrin. Sphere-shaped RBC are more fragile and get trapped in splenic, so there is anemia. Okay, it's normal, normocytic, with associated reticulocytosis in response to hemolysis and increased mean corpuscular hemoglobin concentrate. This is the hallmark of spherocytosis, hereditary spherocytosis. The MCHC is elevated, higher than 40, okay, or higher than 35%, okay. So we have jaundice, acute cholecystitis, fever, right upper, positive Murphy sign, and leukocytosis. This is pigment gallstones leading to acute cholestasis. Okay, this is the problem. But about autoimmune hemolytic anemia, choice B, can present with normocytic anemia and reticulocytosis and jaundice and splenomegaly. but negative comps makes an autoimmune process unlikely. When you study like this, every disease with keyword, you make it easy on you and don't be confused between the choices that look like similar to each other. Okay, so it's an easy question, but please be careful from hereditary spherocytosis. I just want to put this table to you. This is hereditary hemochromatosis. When happen, just know the symptom about the skin, symptom of musculoskeletal, gastrointestinal, endocrine. Okay, this is clinical manifestations of hereditary hemochromatosis. Just this table to memorize and know the disease if it happen in or sorry if in the exam appears the patient with hereditary hemochromatosis, just know the signs and symptoms for this patient. That's it, right? Not important. Okay, everything is good so far. Okay, okay. So, 25-year-old woman comes to the office due to heavy menses. Over the past few months, the patient's period have lasted 7 days rather than the usual 3 days. When you see this problem, do you think this is platelets problem or coagulation problem? What do you think? Yes, that's true. Platelets, because coagulation problems happen in deep organs, okay? Like brain, like skeletal muscle. So the most causes of heavy menses, platelets problem. Let's see. In addition, her menstruation has been unusually heavy and has at times bled through her clothing while at work. The patient is an active volleyball player but has not been able to play recently because or due to increasing fatigue, frequent diffuse myalgia, and bilateral pain in her wrist that requires icing after practice. Now, not something special. She has also noticed that her forearms become easily bruised. Okay, so this is a hallmark for platelets problem. Okay, easily bruised, meaning problem in platelets, or 90% from easily bruised problems, platelets problems. Takes no medication, everything is good, temperature good, or vital signs are good. There are scattered pechiae across the body and large echomyasis on the forearms. The reminder is good. Hematocrit below the normal, platelets very low, leukocytes good, and coagulation is good. Okay? Some APTT is elevated. I will remind you that in the exam, the normal range they will give you. In peripheral blood smear, normal and large platelets. Which of the following is the best next step to evaluation of this patient? We have low platelets. Okay. Should we do antinuclear antibody screen, ascorbic acid level test, or vitamin C level test? Factor 8, say hemoglobin electrophoresis, or platelet aggregation test, or Fenwelbrand antigen level test. Okay. What about B? B that even if there is low vitamin C in the body, but easy browsing, yes, and blood from the gum around the teeth, but no low platelets. Okay, about factor 8, say You don't have to do it because beta and beta T near the normal. Hemoglobin electrophoresis, there's no way. Or about the platelets problem, focus on platelets problem. So let's see the right answer and we will speak about it. This is antinuclear antibody screen, or we have to look about SLE, okay? Or about antinuclear antibody leading to SLE, and this is the hallmark of ITP, okay? So let's talk about ITP and link it to our case. This is commonly acquired. This is autoantibody formation. Sorry, often recent viral or comorbidity, frequently asymptomatic or could have been mucocutaneous bleeding. Severe hemorrhage is rare. Diagnosis of exclusion. This is very, very important. When you see low platelets, you should do all the investigations. When you see everything is normal, okay, this is ITP. We should do HIV, HCV, because this is commonly introduces to ITP. Treatment observation is no bleeding and platelets higher than 30. We should give steroid if platelets below 3,000. IVIG and platelet transfusion if hemorrhage. Okay, so this is ITP because of exclusion, and this is the important things. ITP, leukocyte, erythrocyte count, the fifth line. In ITP, leukocyte, erythrocyte, coagulation studies, all that normal. And the gold standard for diagnosis, peripheral blood smear, normal platelets, but both normal size and large platelets are may be seen due to increased turnover. Okay. Therefore, just the last one, if you need to diagnosis and confirmation, you can do antinuclear antibody testing. Okay. The last one is no confused with you. This is an easy question, but please, there is a lot of distraction. Don't be afraid of, like fatigue, like bilateral pain, icing after practice. Not important. The important things: blood smear and the low platelets and the normal coagulation study. Okay, all of them. Uh, Platelet aggregation test could happen or von Brand problem, but both of them, the choice E and F, will be the platelets normal. Okay? We focus on this point. So let's go to another case. 32-year-old woman comes to the office for a regular scheduled follow-up visit. She has mild fatigue, but no other symptoms. Medical history is significant for generalized seizure controlled with phentoin. So the patient just follow up, no special problem. Take phentoin. Last seizure 6 months. She doesn't use anything. No problem. Examination mild gingival hyperplasia and pallor. Gingival meaning around the gum, around the teeth. Sorry. There is no jaundice or lymphadenopathy, meaning no malignancy. Okay. Cardiopulmonary examination normal. Abdomen is good. No hepatosplenomegaly. Hemoglobin lower than normal. Elevated MCV. Platelets good. Leukocyte good. Supplementation of which of the following would have prevented this patient's condition? The patient take phentoin and has mild gingival hyperplasia, and pallor and elevated MCV. Which of the following have prevented this patient's condition? This is an easy question. This is folic acid, okay? Don't be, don't forget this information. When somebody take Phentoin, we must give him folic acid, okay? Phentoin causes two things: folic acid deficiency, so megaplastic anemia, and gingival overgrowth or hyperplasia. Okay, this is an easy question. No need to more explanation. Okay, let's move to an important question and very important question. Okay, 34-year-old male is brought to emergency room after being involved in a motor vehicle accident. He suffers blunt abdominal trauma and bilateral femur fractures. He has no significant past medical history. His blood pressure is low and heart rate is elevated because of loss of blood. He received several units of packed RBC. Once stabilized, the patient begins complaining of tingling sensation in his toes and fingers. His serum to be low. Calcium, is low. What is the most likely cause of patient's current symptom? What do you think the cause of low calcium? Because low calcium, the cause of tingling sensation. Okay? What the cause of low calcium? Increased renal tubular secretion of calcium, calcium chelation by a substance in the transfused blood, electrolyte leakage from RBC, antibody mediated red blood cell membrane damage, or parathyroid gland suppression due to fluid overload? This is an easy question, but needs to be focused and know the trick of confusion. Yes, yes, that's true. Calcium chelation by citrate in the blood. Please don't forget this information because when we give the RBC, we put in the sac of the blood, we put straight to prevent calcium for doing coagulation. Okay, so we eliminate calcium from the blood. So when we transfuse a lot of blood to another to person, we should give calcium. Okay, because of this problem. So the patient experienced paralysis due to hypocalcemia. Okay, this is the cause. The easy question and the easy answer. So, good. Tell me, do you need any help? Anything need? Good. Okay. So, a 70-year-old man comes to the office due to 6 months progressive fatigue and dyspnea. He has had no fever, night sweats, weight loss, no malignancy. The patient's medical history: benign prostatic hyperplasia, hypertension, mechanical aortic valve replacement for severe aortic stenosis, takes warfarin, tamsulosin, this is for benign prostatic hyperplasia, amlodipine for hypertension. He doesn't drink alcohol, temperature good, elevated blood pressure, pulse good, BMI good, he appears well, nourished and fit. No sclerosis, but the mucosa is pale. No jugular venous distension or lymphadenopathy. Sorry. Cardiac examination good, and pulmonary examination is normal, meaning S1, S2, no problem. Both the liver and the spleen are palpable. This is not good for the spleen. The remainder of the examination, no problems. We have low hematocrit, high reticulocytes, so this is hemolysis. So, and low platelets, creatinine good, INR elevated. Okay, so the patient still has hemolysis. Okay, and coagulation, there are coagulation problems, or we give him a lot of anticoagulation, so the coagulation studies shows INR elevated. Please focus on this problem. When patient you give him warfarin or any anticoagulation, it's normal that INR will be higher than normal. Which of the following is the best next step in management? What we should do? Add MSA. This is for TTP. The 5 of TTP. Don't forget. We speak about the last session. Bone marrow biopsy, no need because no malignancy red flags. Colonoscopy or echocardiogram or liver biopsy. Let's see, this is the right. We should do echocardiogram. Why? Let's go back to the problem, fatigue and dyspnea, and we have no other problem, just we have hemolysis, okay, and low platelets. Let's see why they take this answer, because this is traumatic macrovascular hemolysis. Don't forget that the patient in the second line has mechanical aortic valve replacement. So this is mechanical problem in the blood vessels or in the circulation of the blood. So this is the cause of damage of the RBC. I mentioned it a few minutes before. So what the related of echocardiogram, what we why we should do cardiogram. Okay, the last line before choice A. A transthoracic echocardiogram should be performed to visualize valve function and determine valvular pressure gradients. To see this the problem of hemolysis, this is because of this valve or not. Okay, we should see is there any platelets stick with this valve or no. Okay, so this is the right answer. We don't do no problem for colon cancer, as we see no malignancy red flag, no cirrhosis, okay, no jaundice or uh, liver failure signs, okay. So don't uh, take the cirrhosis as the right answer. Okay, let's go to another case. But before we move on, anyone has any question? Please, you are now. We are now one group, one hand. I will stay with you until your exam. So don't hesitate to call me or text me with any problem you see with the lesson or when you're study. Please don't hesitate to call me about everything you see. Okay? Now we are by one hand to go to pass the Emory exam with higher marks. Okay? You're welcome. Oh, this is you are kind. Sorry. Okay. Thank you. We are. Let's continue. I think we have 19. Sorry, 90 slide. So about when we approach to 45, we'll take a break 5 minutes. Okay? Are you okay with this? Mm, okay, because we have a long session. Okay, maybe in the next sessions we don't need to take a break, but because of this first one and longer one, just today I think we could take a break. Okay, 26-year-old woman comes to the office, progressive tiredness. The patient has no known chronic medical conditions, takes no medication, periods is good. The patient doesn't use tobacco or anything drugs. Examination is no problem. Everything is good except tiredness. Hemoglobin is low. This is the cause of tiredness. MCHC good, so no spherocytosis. Mean MCV lower than normal. Platelets good, leukocyte good. Fecal occult blood test is negative. Okay. Iron therapy is initiated because when we have low hemoglobin, we think about fecal occult blood test as chronic anemia. When the patient returns 6 weeks later, we see their laboratory are unchanged. So we give it iron, but no change after 6 weeks. Which of the following is the most likely cause of this patient's condition? Is this bone marrow aplasia, bone marrow inflammation, circulating anti-RBC, or cobalamin, or cobalamin deficiency, meaning B12, or erythropoietin deficiency? What do you think the cause of this tiredness, even we have periods good? So this is bone marrow aplasia. I don't think this because no lower platelets and leukocytes. Bone marrow inflammation, no problem with malignancy or something like that. So let's continue. Folic acid deficiency, hemoglobin deficit, hereditary RBC membrane defect, iron deficiency, RBC enzyme deficiency, or traumatic hemolysis. The right answer is hemoglobin defect. This is very, very common in the Mediterranean area. Okay, when we see low MCV, the first thing we focus that this is iron deficiency. Okay, you give him iron and go. And if you don't stay with this patient, these patients will die at 2 years. Why? Because this is hemoglobin defect, meaning thalassemia. Okay, it's very similar, and this table is very good to memorize and to differentiate it between iron deficiency anemia and alpha thalassemia and beta thalassemia. The most important things that the three of them lower MCV, but in iron deficiency there's high RDW. RDW meaning difference between higher or bigger RBC and smaller RBC. There's a difference between them. But in thalassemia, all of them the same size. This is RDW. RBC in iron deficiency will be low, but in thalassemia normal. In smear, in thalassemia we see target cells. So serum iron studies no need to do, or sorry, you should do to differentiate between them. Don't give another iron after 6 weeks. Okay, so this is also another table to differentiate to know thalassemia. Okay, so this is hemoglobin or thalassemia. No need to other choices. Okay, so when you see lower MCV, please ask for iron studies. Don't give iron empiric. Okay? You should focus the cause of low MCV and the cause of anemia. Okay. A 68-year-old man is brought to the emergency department with 2 days of bright red blood per rectum, complaints of feeling dizzy, and extremely fatigued. 6 months ago, he had a vertical bleed that required hospitalization. The patient has moderate chronic or COPD, and he uses his inhalers regularly. 3 weeks ago, he was hospitalized for COPD and also found to have a right femoral and popliteal vein thrombosis. He was charged on warfarin. From here, the case study. Okay, start. Sorry. All of the up lines, distraction. Just we focus from the later. His mobility impaired by right hip, or etc. Low blood pressure, high HR. Mucous membrane are pale, the abdomen soft and tender, swelling of the right ankle and calf, low hemoglobin. Okay, INR elevated. Warfarin is stopped. So the problem happened when we give warfarin, low hemoglobin. Okay, this is the abstract of this case. Swelling of right ankle and calf. So the blood goes to these parts, okay, or to these parts, okay. So warfarin stopped. His volume resuscitated, given a blood transfusion and fresh frozen plasma. We do lower endoscopy, the vertical bleed, which of the following best management for this patient's deep venous thrombosis. So when we give him warfarin, more blood comes from the verticular. Okay, so we stopped warfarin, but we should do something else. We should give him uh, uh, medication, okay, because he has vein thrombosis. Okay, so what we should do for patients DVT? This is very important question. When somebody has DVT, don't give him warfarin at first. We should give him initiate unfractuated heparin. This is memorize, okay? But please focus. When you have someone has DVT, the first line you should give him heparin. But in this case, we should do place a retroviable inferior vena cava filter. Why? You should memorize this table. When you have DVT, proximal DVT, meaning proximal higher than the knee, popliteal or femoral DVT, we should focus if there is pulmonary embolism, yes or no. If there is hemodynamic instability, yes or no. If there is problem with hemodynamic or pulmonary embolism, okay, or yes, by meaning to the right, or massive proximal. If these problems happen, let's go to thrombolytics. Should we give him or not? If there is a contraindication to thrombolytics, so don't give it. Consider mechanical thrombectomy or surgical thrombectomy. Okay? So let's focus. This patient has DVT. Okay? But he has hemodynamic instability. So let's go to thrombolytics. If we could give him, okay. But if not, go to mechanical thrombectomy. If there is no pulmonary embolism, or hemodynamic instability, go to contraindication to anticoagulation. Okay. If there are no problem, give him anticoagulation. If there is problem, give him IVC. So to conclude, our patient has DVT, but in hemodynamically now, what after INR, he is volume restricted, resuscitated with blood transfusion and fresh frozen plasma, meaning now he is hemodynamically stable. Okay, so at first no stable, but now he's stable, so no problem. But we can't give him anticoagulation, we can't give him heparin, okay, because he has bleeding from the verticular. So we give him IVC filter. Understand? He's bleeding, DVT, but he has high risk to PE, so we should give him emergent anticoagulation, but we can't give him anticoagulation, so we give him IVC filter. Okay? Understand or need some help? This is why we can't. Because he has bleeding in the diverticular. Okay? He has active bleeding in the last lower endoscopy, the last line. The lower endoscopy reveals a diverticular bleed. So we can't give him anticoagulation because the bleeding will continue more or be a massive hemorrhage. So we can't give him heparin or anticoagulation. Okay? This is the cause of we can't give him. Okay. Good. Do you need any help? Not second line, because of sorry, because there's contraindication to anticoagulation. Maybe in heparin, give him warfarin after 3 days, or give him 10th factor and antibody or something like that. This is the second line. But we have a contraindication to anticoagulation, so go to IVC. Okay? To be focused, not second line, when we have contraindication to anticoagulation. Okay. So this is very important question. Some in the past year, there is a similar question to this case. Okay. 41-year-old, have fatigue, feeling short of breath while riding his bike to work. It's unusual. No chest pain, no other problem, no prior medical condition, no medication. Occasional drinks alcohol, no other problem. Vital signs are good. Physical examination, moist mucous membranes, normal thyroid, everything is good. Abdomen soft, normal sound bowels, low hemoglobin, low platelets, low WBC or leukocytes. We show numerous atypical leukocytes, some of which contains cytoplasmic occlusion. Okay? C. When you have this WBC, this is unnormal. Okay? This patient is a greatest risk of which of the following due to his current condition. This case, diagnosed by blood smear. Let's see what the problem of this type of leukemia cause. This cause conception coagulopathy. Okay, let's see what this case is. To read this blood smear on the left, abnormal promyelocytes, and we have abnormal promyelocytes with oil roads. Okay, see these roads? This is a hallmark for APL, or acute promyelocytic leukemia, that goes pancytopenia, and we have AUER roads. Okay, this is medical emergency that because it's high risk for pulmonary or cerebrovascular hemorrhage from tumor-induced conceptive coagulopathy. In other words, this type of leukemia take the coagulation factors and could cause a massive hemorrhage. Okay, so just memorize this type of acute promyelocytic leukemia could happen massive hemorrhage. Just another type of malignancy. Don't read it carefully because it's not that important like APML, or sorry, APL. Okay, just APL. You see our roads. Be careful from massive hemorrhage. Just so we have 26-year-old man comes to the office due to several months fatigue. No problem. Just have occasional leg cramps. Takes lisinopril and atorvastatin. No longer cigarettes, but has a 30 back year history. Blood pressure good. No alcohol. We have pale. Everything is good. Just 2 from 6 ejection murmur. Not that important. This type of ejection murmur comes from anemia. Okay, this type of ejection murmur comes from anemia. The abdomen good, no mass, no rash, no edema, low hemoglobin, MCV lower than normal, platelets and WBC good, BUN creatinine good, ferritin and serum normal. What? Or sorry, lower than normal. The normal higher than 10. Which of the following most appropriate next step to management? What we should do? Biopsy, no malignancy signs, discontinuation of atorvastatin, or endoscopic evaluation, serum CRP, serum erythropoietin, or serum free monoclonal light chains. This is an easy question. We have 62 man and iron deficiency anemia. Okay, because of two things: MCV low and ferritin is low. So this is iron deficiency, and we should do endoscopic evaluation looking for hemorrhage. Okay, so this is anemia from iron deficiency. We should focus on blood loss, so we should do endoscopic evaluation. Okay, to exclude malignancy. It's even an easy question. Okay, let's move to another question. Very important, just one information to keyword on. 36-year-old man, progressive fatigability, significant for TB, pulmonary tuberculosis, 2 months ago. He take isoniazid, rifampicin, ethambutol, pyrazinamide, hemoglobin low, MCV low, MCHC is good, ESR good, iron serum good, low, or sorry, low than normal, total iron or tips lower than normal. A microscopy reveals two population of RBC, some kind of hypochromic and normochromic. What we should do when you see tuberculosis and isoniazid, this is, we should give pyridoxine or P6. Let's see what this is. This is kind of acquired sideroblastic anemia. Let's see this problem. Sideroblastic anemia consists of different types of anemia that defect in heme synthesis. Okay, this is the more problem, but they can be congenital or acquired. Acquired is more common. So meaning sideroblastic anemia problem by heme synthesis. Okay, acquired happen with alcohol, the fifth line, malnutrition, medication that lead to pyridoxine dependent impairment. This is the early steps of protoporphyrin in the mitochondria. So he take isoniazid. So we should give him B6 with it. Okay. The hallmark for acquired sideroblastic that we have dimorphic RBC population. So we should give him pyridoxine just like that, as easy as possible. This is another table for iron studies in microcytic anemia. We talked about it before, and this is another table to memorize it. Okay. A 25-year-old comes to the physician with 6 weeks fatigue, no problem, no medication. If you see that we read the case faster than before, and I need to practice this skill with you. You should do this skill. You should focus on the important things and forget a distraction problem. Okay, to save your time in the exam. No, so fatigue until now, no problem. Blood pressure good, heart rate good, respiration good. Pallor, icteros, and mild jaundice. Splenomegaly. So we have hemolysis, hematocrit low, WBC and platelets good, bilirubin elevated, no problem in the kidney, LDH elevated, haptoglobin good. But we have reticulocyte count. Okay, we have spherocytes without central pallor. We have direct comps test is positive. So this is autoimmune hemolytic anemia. I just want to repeat this question to don't forget. Spherocytes, positive comps. So welcome to autoimmune hemolytic anemia. This is causes of hemolysis. We speak about them before, and it is to memorize them. And warm and cold, we speak about them. This is another table to memorize them. So, a 32-year-old comes to emergency, pain and swelling in right leg. No fever, chest pain, or another problem. The patient was hospitalized 2 weeks ago for right lower extremity DVT. Discharge on warfarin. This scenario is similar to the scenario before. INR good because goal between 2 and 3, and taking warfarin daily. However, busy work, his dietary intake variable, and missed his clinic appointment for anticoagulation monitoring. No other problem. Vital signs good, but he has pre-tibial edema in the right leg. His INR low. Okay, so this is problem because warfarin isn't work good. Everything is good. We do venous Doppler. He still have or a new DVT. Popliteal vein thrombosis. This is popliteal to femoral vein. Worse than on previous ultrasounds. So warfarin isn't good. What is the best next step What we should do: increase warfarin, initiate thrombolytic therapy, place filter, replace warfarin with rivaroxaban, or start low aspirin. Remember that table. We give him aspirin and no anticoagulation contraindication. So we can give him replace warfarin by rivaroxaban because the warfarin isn't work good with him. تمام? Good. So treatment. This is the difference between warfarin and oral factor XA inhibitor. No problem between them. But when we give him warfarin and isn't good for him, we can switch to XA inhibitors. But no need to filter. Okay, so this is DVT. We can give him another or replace the warfarin to rivaroxaban. No need to INR monitoring or required for overlap therapy because he missed a clinical appointment, so don't need to watch INR and see the coagulations. No, just give him rivaroxaban and leave him go to the work. Okay, when you have a patient not coming to the session or clinic appointment, give him rivaroxaban and leave him go to his work. Okay, so just to memorize the anticoagulants and their mechanism of action. This table is also good where factor XA inhibitors work: rivaroxaban, apixaban, or fondaparinux. Okay, this is the anticoagulation drugs. Everyone where work. The heparin works on factor 10 and factor 2. Looks to areas of intervention. Heparins in red work on 10 and 2 factors. So, easy question. A 60-year-old man comes to the office because he have low blood count. The patient, let's see, has anyone talk to me? Sorry to not go to message. Okay, what's conspiration throw? Okay. This type of WBC stick or take the coagulation factor from the blood. It's not fully understood. Okay, not fully understood. So, not so low. So if they know, they will write to us. So not fully understood. Okay. 60-year-old. Sorry, we have low blood count, but everything is good. No chronic, but has been treated pneumonia twice during the past year. No medication, vital signs good. We have pallor, no enlarged lymph nodes, abdomen is good. The spleen tips is palpable, 5 below the left costal margin. So we have splenomegaly, but liver is good. We have stool GAG negative. We'll see it in gastrointestinal topic. CBC, low hemoglobin, MCV good, platelet and leukocyte good. We do blood smear and we see this. Just see this type of WBC. Just this confirmation of hairy cell leukemia. Just like that, as easy as possible. This is hairy cell leukemia. This table, if you need to know more about this leukemia, but the important things when you see this hairy cell, this is hairy cell leukemia, just like this. So, 74-year-old man, 3 months of problem of old age, so no problem. He has daily temporal headache, fatigued, the patient's ear ring, his eyes become blurry, both feet feel as if someone sticking them with electric pins. Okay, we'll see something like that when we go to or back to the neurology. The patient used to smoke cigarettes, but now good. Temperature good, vital signs good. He is moderate cervical lymphadenopathy. Cardiopulmonary examination normal. Hepatosplenomegaly. We have fundoscopy, dilated segmented. Tortoise retinal veins. There are sensory deficit in his feet, but reflex and tricks are intact. Let's see what there is or what the hematologic problem. We have low hemoglobin. Everything is good. Another serum chemistry is good. Serum protein electrophoresis reveals a sharp IgM. Now start the question. We do electrophoresis. What is most likely diagnosis for this patient? I just want to focus on two things cause sharp IgM spike. Just two things. Multiple myeloma and valdesterone macroglobulinemia. Okay, and now we have valdestrone the problem because no bone pain like multiple myeloma as we spoke about last session, no osteolytic lesion, no hypercalcemia. So we have valdestrone and the patient has hyperviscosity syndrome like problem in ears, problem in the brain. So we have headache, okay, and hepatosplenomegaly that we can see in multiple myeloma. Monoclonal IgM accumulate in the blood. We see Rolex for both multiple myeloma and valdestrone. When we do bone marrow biopsy, more than 100% clonal B cells. This is valdestrone, or if it is plasma, so this is multiple myeloma. Okay, it's an easy question. A 35-year-old woman with no past medical history, hospitalized with severe shortness of breath. She also has swelling and tenderness of her right calf. CT angiogram shows pulmonary embolism, just like that. From now, start the case. We do compression ultrasonography. We see a right femoral vein thrombosis. Started on anticoagulation in 6 days. Right arm pain. Physical examination shows cold right upper with no peripheral pulse. This is a very big problem. Hematocrit low, platelets at low. When presentation to 246, now 76,000. PT, APTT is elevated. So, which of the following drugs was most likely used to treat this patient DVT? Just focus. The patient has PE and give him anticoagulation. And now there is thrombosis. So, cold upper extremity, no peripheral pulse, no peripheral pulse. So, this is thrombosis and low platelets. This is cause of unfractionated heparin, or by meaning HIT. What the meaning of HIT? The second line, heparin-induced thrombocytopenia. Okay, there's two types between them. Both of them cause low platelets and uh, thrombosis. So type 1, non-immune of heparin, and the first 2 days of heparin exposure, the platelets count then normalize with continued heparin therapy, no clinical consequences. But the more problem or more serious immune-mediated disorders, the antibodies to platelets factor 4 happened with FEF2 10 days after initiation of heparin may lead to life-threatening consequences. Okay, the other drugs don't cause low heparin. Okay, I'll start here. Stop here. Just oh, sorry. This case, I will share this PDF with you. Still 10 slides. It's an easy one, no problem. About uh, just this picture. This is skin necrosis. In black. Okay, focus on skin black on the back of head. This is because of using warfarin cause protein C deficiency. Okay, just know this information. When you give the patient warfarin and skin necrosis, black necrosis on the body, this is because of protein C deficiency, and this is the explanation. And another one, when you have problem, regardless of the case, when you have the fifth line of the fourth line at the end, we have several enlarged, non-tender, firm cervical supraclavicular lymph nodes. When you see supraclavicular lymph nodes, this is problem. Okay, this is malignancy. What you must appropriate to establish diagnosis when you see bad prognosis, please do excisional lymph node biopsy. Okay, just like that, as easy as possible. I will repeat: when you see mass, firm, or suspicious, do excisional lymph node biopsy, regardless of the case. I repeat them at the end just to focus on these key points. Hodgkin lymphoma, this table important to it. And the last one, finally, 42-year-old mildly overweight man is being evaluated for his second episode of DVT in 2 years. Both episodes unprovoked, happened by incidence, no recent prolonged immobility, long distance travel, or something like that, no problem. Has no past medical history. We do thrombophilia workup. Which of the following drugs is most likely lead to low protein S levels? Like protein C. What the cause of low protein S or protein C? The drugs is warfarin. Just like that. Okay? So warfarin make protein S and protein C lower than normal. That cause thrombosis. Even warfarin used as anticoagulation, but could happen thrombosis due to protein S and protein C deficiency. Okay, and thank you very much. I know this session is very long than usual, but until the exam, we will still like that. Okay.